Hi, good evening. Who's the medical students in the room? Okay, I'm gonna pick on you guys, I'm sorry. Like she said, I'm Katie Wright, I'm one of the chief residents at Bumpsy. I've lived here for 5 years, really enjoyed it. Don't plan on leaving the Dallas area, so want to stay. And I'm gonna do a trauma critical care fellow.
This is not the Dallas area, by the way.
Well, the Metroplex,
Yeah.
the Metroplex.
Yeah.
I spent 50% of my time here, 50% of my time in Dallas, being a
We'll see
Baylor.
if we can correct that.
So one of my interests is ECMO and trauma. It's kind of a developing area of trauma surgery in need of a lot of research, and we do a lot of it at Bumpsy. And we're probably the only program in the country where our surgical intensivists actually cannulate and manage the ECMO, which is really unique. It's hard to find that. Usually it's cardiac anesthesiologists and CT surgeons who manage the cardiac ICU and do all the cannulations. So we have a unique experience there. So disclosures, I have none. These are objectives. Basically, we're going to define ECMO, what are the indications for ECMO, our treatment goals, and the complications of ECMO. So we're going to start with a case. This is patient MW. He's a 14-year-old male who presented to our trauma bay with a gunshot wound to the abdomen. He was hypotensive tachycardic on arrival. GCS was 8, so he was intubated in the trauma bay, started massive transfusion protocol, and then went upstairs for an emergent trauma laparotomy. His injuries included a grade 5 renal lac, a right colon injury, and an IVC injury. He did well after surgery initially. He was resuscitated appropriately, was admitted to the ICU. On post-op day 1, he developed severe respiratory distress requiring maximum ventilation support without any improvement. So he was on 100% FiO2 and a high PEEP. So what could be the cause of his respiratory failure? Let's start down the line. Yeah. Mm-hmm. Mm-hmm.
The IVC.
How could that cause his respiratory failure? You can ask for help.
Could you have reemergence of the hemorrhage from one of the surgical sites, and then it's causing like pressure onto the lungs itself?
So abdominal compartment syndrome could be something that could cause respiratory distress. You would see a big distended belly, they'd be hypotensive, their lungs can't inflate, so that's why they can't breathe. Their bladder pressure would be elevated, so that's a good one. Anything else? No? So he can have transfusion-related acute lung injury, which when somebody is getting massive transfusion protocol during a trauma, you have to do it to save their life, but it does have negative side effects. Trolley is one of them, and that is different than acute respiratory distress syndrome. He can have heart failure, right, which would be unlikely in a healthy child. A pulmonary embolism. Why is this a patient more at risk for a pulmonary embolism on post-op day 1? Let's go back to his injuries. So he had a grade 5 renal lac, a right colectomy, and an IVC injury. He has a hole in his belly, gunshot wound in the belly, and a hole in his big vein going back to his heart. What if I said his chest x-ray looked like that? So that's a bullet embolus. So the bullet went into his IVC and then to the heart and was pumped to the lungs. So he essentially had a giant, massive PE, and that's why his lungs were failing. So indications for ECMO and trauma, ARDS or acute lung injury, a massive PE like this patient, cardiogenic shock, and hypothermia. Cardiogenic shock is a little different kind of ECMO than we're going to talk about throughout this talk. So ECMO is not new, but new in the use of trauma. There's not much research on the use of ECMO in trauma, but here is our medical reasons essentially for using ECMO and the types of evidence, research-based evidence they have. So for respiratory ARDS and bridging to lung transplant, they probably have the best research. So ARDS is the randomized controlled trials, cohort studies. Then when you get to the cardiac, you have MI-associated cardiogenic failure, myocarditis, somebody bridging to transplant with either a VAD, and then eventually they progress to ECMO. And those are all cohort studies or case studies. So for ARDS, the criteria for ARDS are bilateral infiltrates on chest x-ray, unrelated to heart failure and hypoxemia. They have a chest x-ray that looks similar to this. And then we define ARDS into 3 categories: mild, moderate, and severe. And you look at your P to F ratio and your PEEP to determine which one it is. So mild is a P to F ratio less than 300 and a PEEP greater than 5. Moderate is P to F ratio less than 200 and a PEEP greater than 5. And severe is P to F ratio less than 100 and PEEP greater than 5. So conventional treatments for ARDS, you want to keep these patients on a low tidal volume. So we usually use 4 to 6 cc's of lung volume per kg. That's protective. You want a high PEEP. You can prone and paralyze these patients. And then HFOB is one of our ventilator support systems, which is actually falling out of favor. There is a recent article that actually showed that HFOB increases mortality in patients with ARDS, so people are trending away from it. I don't know, has anyone rotated in an ICU yet? So HFOB is this very loud machine. It sounds like a lawnmower in their ICU, and it's a high pressure ventilation system, and it comes with a lot of side effects to the lungs. They can have spontaneous pneumothorax, and it can be dangerous and not in the right hands. So people are moving away from it. So just some ECMO basics. So ECMO allows for bypass of blood of the lungs or the heart and the lungs to oxygenate and pump blood when a patient is unable. So you have 3 categories for ECMO. You have VV ECMO, which is what we're mostly going to be talking about. So that's veno-venous. So 2 cannulas and 2 veins. You have veno-arterial, which is VA ECMO, so a cannula in an artery and a cannula in a vein. And then VAV ECMO, which is 2 cannulas and 2 veins and 1 cannula in an artery. So components of an ECMO circulation, it's pretty complicated. We'll see a picture a little later of what an actual ECMO device looks like in a patient's room. So you have a vascular cannula, which goes in for VV ECMO, would be a vein and a vein, so 2 cannulas. And then you have a drainage reservoir or a bladder, which holds the blood. And this allows the pump to have continuously available blood. So the cannula pulls blood out of the body, and then it sits in the bladder while the pump is working. You have a pump to roll the blood, which consists of a roller head and a centrifuge, and then the artificial lung, which actually oxygenates the blood, and then a heat exchanger, which warms the blood to put it back into the body. So this is kind of a schematic of how ECMO functions. So the first one is a cannula in the right IJ, which is taking deoxygenated blood from the heart out into the ECMO pump. So you have the centrifuge and the oxygenator, and then oxygenated blood goes back through the femoral vein into the body. The second one is the same thing, just reversed. So you have your pulling perfusion cannula into your femoral vein, and then you're putting oxygenated blood back into your IJ. And this is what the cannulas look like at bedside. So it's kind of hard to show VV ECMO in one picture because their cannulas are usually top to bottom. But this is a VA ECMO example. So you have 1 cannula in an artery and 1 cannula in the vein. And then the green cannula is called a reperfusion cannula, and that goes just distal to your arterial cannula, so your blood still gets blood flow. or your foot, sorry, your leg gets blood flow. And this is what ECMO looks like at bedside. So this is actually an ECMO device in an ICU or a neonatology ICU. So babies get put on ECMO quite frequently when they're born prematurely. And this is what it looks like. The new machines now are starting to get a little smaller, more compact, but overall there's still a lot of things that go along with it. And to run one of these machines, you have to have an ECMO perfusionist, a bedside nurse who's experienced in running ECMO, because they have to make sure the cannulas don't get pulled out, that the heparin is dosed appropriately. There's a lot of things that go into it. So those two people plus your respiratory therapist, because these people are most likely going to be on a ventilator, a critical care doctor, usually a transplant surgeon or a heart surgeon, or a heart failure cardiologist. So there's a big team of people that are taking care of these people in the ICU. So the broad treatment goals with ECMO, so you want to remove CO2 and oxygenate the blood, which is normal, right? That's what your lungs and heart do. You want to improve oxygen delivery and then allow normal physiologic metabolic at the level of the tissue. You want to provide lung rest and cardiac offloading. So managing patients on ECMO. So the most important thing once you have your patient cannulated in the ICU is you have to anticoagulate them, because this is not a normal process, right? The heart and lungs pump blood to the rest of your body with oxygen in them. Now you're taking all the blood out and it's running through a pump. Your hemoglobins and red blood cells aren't used to that, so they can clot, and you're going to also destroy some of your blood products while it's going through this process. So you want to make sure you anticoagulate them. So during cannulation, when you're clamping arteries to prevent them from clotting, you're going to give them a bolus of heparin. And then you want to have a heparin infusion afterwards, and you want their PTT to be around 50 to 70 seconds. And the goal anticoagulation can be targeted to many things. The PTT, a tag, an anti-10A level. There's lots of things that you can track. So modes of support, this is our VB ECMO. So the blood, like I talked about earlier, is withdrawn and reinfused into the venous system. We usually use the jugular femoral veins just because they're easy to access and they come with less complications compared to subclavian veins. You can use double lumen cannulas or single lumen cannulas. If you use a double lumen cannula, it's like this picture. You have one cannula in the IJ or the femoral versus the two in separate veins. There are some pitfalls to that we'll talk about in a little bit. So you either have two access sites or one. So unique features of VV ECMO. So this depends on your native heart to actually pump the oxygenated blood from the ECMO circuit to your body. The amount of output depends on the amount of venous drainage from the patient. So if your cannula is not very big and you're only pulling a little bit of blood from this body every few seconds, then it's going to take a long time to pump it through the system, right? So the pressure difference between the venous blood column and the reservoir, the bladder that we were talking about, is affected by gravity. So that's part of the nurse's job to make sure the whole system is set up appropriately the way it is at bedside. And then the number of drainage sites and diameter of the venous cannulas are important too. So we don't put normal central lines into these veins and arteries. We're putting massive cannulas, sometimes 16 French cannulas in the vein and artery. So if you're putting a big hole in somebody's vein to put the cannula in, there's a lot of side effects of that. In the artery, you can injure the artery, you can clot the artery off so the rest of their foot or leg isn't getting blood supply. You can rip a hole in the vein and cause massive bleeding. So when you're doing this, you have to be trained and certified to do it because it is dangerous, or can be dangerous, I should say. So the other thing I wanted to talk about is recirculation, which is a phenomenon with the one-site access ECMO that we were just talking about. So this is when you pull and return blood through the same catheter. And it's a phenomenon where the blood returned from the infusion cannula is drained by the drainage cannula before going through the heart and returning to circulation. So essentially you're pulling the oxygenated blood that you just put back in out of the body. So you're just reoxygenating the same blood. So to prevent this from happening, that's why we use the 2 cannulation sites. So 1 cannula in the groin and 1 cannula in the neck. So this is what a double lumen cannula looks like. We do use this at BUMC. These patients who have this are more likely to get up, move around. You'll come to the cafeteria at BUMC and you'll see some of these patients in their wheelchair walking around with their nurse pushing the ECMO pump behind them because it's just one access site in the neck. It's easier to walk around and they can be more mobile. But you have the reperfusion cannula issue. So the blue arrows are showing your deoxygenated blood, and the red arrows are your oxygenated blood coming back in through 1 lumen. But what happens with the reperfusion cannula problem is the red arrow goes straight back out into the deoxygenated cannula spot, which is not helpful for the patient. So how do you make sure that your ECMO is actually working? So you can look at a few different things. You want to optimize your hemoglobin, so you want them around 13 to 14. Their blood flow rates through the ECMO machine should be 120 to 140 mLs per kg per minute. So you're pulling a ton of blood out of these patients. So you can imagine if a cannula comes loose and falls out of a vein, these people can bleed to death very, very quickly. And then you want to have your low recirculation factor. So how we monitor this is you monitor the patient's cerebral oxygen saturation, the recirculation factor, their oxygen saturations. So what are the complications of VV and VA ECMO? So the first 2 are specifically for both of them. So with VV and VA, you can have an embolism or hemorrhage like we talked about. The hemorrhage rate is pretty high. It's 17 to 21% of every patient on ECMO because you're heparinizing them, right? For VA ECMO, you can have LV distension, aortic root thrombus, differential hypoxemia. That means the legs are getting oxygenated blood and the arms or upper body is getting deoxygenated blood. So their upper body will literally look blue and their lower body will look red and perfused, and limb ischemia. So ECMO versus conventional treatment of ARDS. So we're going to go through some studies right now and just kind of go over the recommendations. So this is a study outside of Burlington, Alabama, Birmingham, excuse me. So this is a trauma paper that looked at 15 patients from 2012 to 2013 compared to 14 of their historical cohort, which was just managed with essentially ventilator in severe ARDS. This paper showed no significant difference between their hospital length of stay, ICU length of stay, and vent-free days, but it did show a decreased mortality in the patients who were treated with ECMO. So their ECMO patients with severe ARDS had a 13% mortality versus a 64% mortality with just conventional settings. This paper also looked at ECMO in blunt thoracic trauma with pulmonary contusions, essentially. And this showed that their hemorrhagic complications were in about 29%, so 25% of people, and their survival rate was 74% with the ECMO. Obviously, a shorter duration of ECMO and VV ECMO predicted survival in these patients. Again, this was only 85 patients and it was a retrospective review, so it's not the best literature, but it's the only kind of literature we have on ECMO and trauma. And then this paper showed VV ECMO improve survival in adult trauma patients with ARDS. So this again was a retrospective review. It was only 26 people or patients, and then it showed an adjusted survival greater in the ECMO patients versus conventional. So who is a candidate for ECMO? This data is really hard to find. It really doesn't exist. So I pulled these recommendations from shock trauma because they're obviously well known in the trauma world. So their inclusions would be anybody who's post-traumatic pneumonectomy, which is extremely rare. So that means during a trauma, you have to remove someone's entire lung, so they only have one lung to live on, and you're kind of supporting them with BB ECMO until that lung can recover. Anyone with a PaO2 less than 100 with an FiO2 greater than 80. And then hypercapnia is also one of their criteria, or if the patient is unable to ventilate on APRV, which is another ventilator mode that we use in ARDS. They have to have a ventilator day less than 10 days. Their age has to be less than 65, and they have to have a reversible form of ARDS. And it can also be at the bedside physician's discretion. Their exclusion criteria include age greater than 65, the pre-admission use of HOMO2, a terminal disease that's less than 1 year of survival, a Jehovah's Witness. Why would that matter? Let's go down the line. And these people are going to bleed, right? They're trauma and you put them on heparin, so they're probably going to need blood. Plus you need their hemoglobin to be 13 or 14, so you're going to transfuse them to get them up there. Cirrhosis with a MELD greater than 30, uncontrolled hemorrhage, abdominal compartment syndrome, because you can fix abdominal compartment syndrome and potentially fix their respiratory distress by just opening their abdomen, so maybe they don't need to be put on ECMO. A severe TBI, which makes sense, right? If somebody has a severe TBI, you don't want to give them a bolus of heparin and make their head bleed worse. And then again, bedside physician discretion. So is ECMO safe in a trauma patient? I just told you how much heparin you give these patients and how often they bleed. 25% of patients do bleed. That's a lot. You just don't bleed because of the heparin drip. You're also pumping their blood through this pump, which is going to cause their blood to hemolyze. It's also going to give them a induced or acquired von Willebrand syndrome because it destroys the platelets as it goes through. And then again, bleeding and TBIs. You don't want to bolus them with heparin and then make their platelets not work. So this paper is very small. It's basically only case studies. So it's showing that it is actually safe to give people or put them on ECMO, but you can't give them that heparin bolus or put them on a heparin drip. And they're saying that with the new technology of the new centrifuges and circuits that are heparin coated, that you don't need to necessarily bolus these patients, so it may not clot, the pump may not clot, and you don't have to give them heparin. This is like a handful of patients, I think it was 6 total, and one of them actually had a cariny and was still put on ECMO and never bled, and they were calling it like heparin-free ECMO. We have never done this at BUMC, but it is happening, so I'm sure it's going to come soon. So the ethical questions with ECMO, it's not a life-saving measure for everyone. You really have to pick your patients appropriately. Sometimes when you make decisions in the heat of things, when somebody's dying and you place them on ECMO, you don't realize the consequences of it because this person may have an anoxic brain injury from being down too long, and now you put them on ECMO, and yes, their heart and lungs are functioning and their body is warm, but they're brain dead. So what do you do then? Do you talk to the family and say, yeah, your loved one is warm and their heart is technically working, but their brain doesn't work. So then you take them off ECMO. I've been involved in some of these situations, and the family takes it very hard because they think they're the ones actually killing their loved one or taking their life away, which is not the case. So you always have to have an end game when you're considering putting, especially a trauma patient or really anyone on ECMO. You have to have a plan. Like, this is not going to bridge you to something. Some people can stay on ECMO for 60 days waiting for a heart transplant, but the trauma patients aren't those people. So you have to say, we can try this, but at the end of 7 days or 2 weeks, whatever the plan, the physician team decides, that you need to make sure you have that end date before you actually put somebody on ECMO. And then also you have to think about the severe TBI patients. Like, can you limp them along through their ARDS? Because a lot of them have aspiration pneumonia or pneumonitis and then eventually go to ARDS and they're not doing well on the ventilator. Do you put them on ECMO for them to really have a poor quality of life at the end of the day? So there's a lot of things to discuss with families before you do this. And then we've had a few incidences at Baylor where the argument is to put a trauma patient on ECMO for a potential organ donation, or maybe they were already an organ donor and they suddenly start coding or their lungs aren't doing well and they're trying to like match the organ somewhere else. Do we put that patient on ECMO to kind of bridge them to their transplant and give life gift or the other people a little more time to like place the organs? So that's been brought up a few times, and there's really no answer for that. I think it's physician discretion and coming up with a treatment plan. And then also the cost. Does anyone know how much it costs per day to put a patient on ECMO? It's $44,000 a day. That's just the cost of it. That's not what the patients actually pay for or get billed. So for hospital costs, it's $44,000 a day. And then, is this feasible for our patients in the Metroplex, specifically at JPS? Can our patients afford that? Is it something that we should be offering them? Does it show a difference? The research, it's very split, and it's not the best research. So there is this paper that recently came out, the EOLIA trial. This paper showed that there was no difference between ECMO and conventional ARDS treatments with the ventilator support. But with this paper, the trial actually had a high crossover rate. So about 28% of the patients who were in the conventional arm were transferred to ECMO and placed on ECMO because they were failing conventional treatment. So it really doesn't give us any definitive conclusions. CRRT, which we've all seen in the ICU, there's not been one paper that shows that it actually improves mortality, because you're not going to withhold something, a technology that you have from a patient when their kidneys are failing and they're acidotic and their potassium 6. So you put them on it. So in that case, again, there's not going to be a paper that shows a difference. So this paper is out of Britain, Great Britain. So it's an interesting paper because it doesn't argue to put people on ECMO. It argues that you transfer these lung injuries or ARDS, like severe ARDS patients, to an ECMO center. And they're saying that it's more economic and the patients actually do better and have an improved survival, not because they're going to be placed on ECMO, but because the ECMO center is usually better at treating ARDS, whether it's placing the patient on ECMO or with the conventional settings. So I think that's something to remember. And if you're struggling, maybe there's a specialist somewhere else at a tertiary center that you can transfer this patient. And it did show that money-wise, it's actually a good idea to do that. So ECMO in the Metroplex. So there's a few centers in the Metroplex that offer ECMO. Obviously, BUMPSy, UT Southwestern, Bass recently just started their program. I think they only have a few beds, and they're mostly doing it for the CT surgeons. And then Baylor Heart and Vascular Hospital in Plano, they also do it, but again, it's mostly for the CT surgeons and their heart patients. BUMPSy is the only program with the surgical critical care and trauma docs that are running the unit. So if you're obviously wanting a trauma patient on ECMO, it's probably the best place for you to transfer. UT Southwestern just recently lowered their bed numbers. They only have 4 now, and BUMPSy has on average 9 beds running, but we have 35 beds total. So back to MW. So he, on post-op day 1, was placed on VV ECMO. Unfortunately, his right heart failed, secondary to the bullet emboli. So he was then transitioned from VV ECMO to VA ECMO on hospital day 3. He spent 24 days in the ICU. His length of hospital stay was 49. He did have a complication of lower extremity ischemia from his cannulation for his VA ECMO, and he required developed compartment syndrome of his lower extremity and required fasciotomies. But he walked out of the hospital, was discharged to a pediatric rehab, did really well, spent 2 weeks there, and then was actually seen again in the hospital a few months ago. But he's doing well. So where do we go from here? What we really need to focus on is more data in ECMO. They're all retrospective in very small groups, which really doesn't help when you're trying to make an argument to a hospital saying, you know, I think this patient needs to be transferred here for ECMO, or when you want to start your own ECMO program at the hospital. So we really need to start focusing on that. I know I'm trying to publish some of our data from BUMPSy, so hopefully in a few years this will change. And then not every level 1 trauma center has access to ECMO. JPS is a level 1 trauma center. We see all sorts of things over there, but we aren't able to keep somebody in-house and provide them ECMO. We can cannulate them and call our own perfusionists, and our cardiac surgeons know how to do it. And we've done that before, but once you get them cannulated, you have to transfer them. And then for each individual center, I think it's important to discuss the criteria in which patients you're going to say this person's an ECMO cannula or candidate, because delaying them, the opportunity to be put on ECMO is usually their demise, because you wait too long until you can't transfer them. They're too sick to go. So start thinking about it when you have, you know, patients with terrible lung injuries. Start thinking about it early. Any questions?
I enjoyed your paper mainly because I've been retired for 17 years. I didn't know this existed. But have there been any cognitive problems and non-brain trauma like you do after cardiac bypass?
For ECMO, so embolism is a risk. So some patients can have a stroke when they're placed on ECMO. So somebody who came in without a brain injury and eventually developed ARDS from, you know, let's say trolley, and they are put on ECMO, it's always a risk, but it's very low in the trauma patients. I think it was like 3 to 5%. Bleeding is usually what happens. Like these patients, I've cannulated somebody for ECMO, and then the next day I put a chest tube in them, which is really easy. I mean, I do that every day on the floor with no cautery, no nothing. And with these ECMO patients, they bleed so quickly. You put a chest tube in and they'll bleed to death from it. So you have to be very, very meticulous with every procedure you do on them. Arterial lines, central lines, really anything they can really bleed from and create a big problem.
For, I guess, the use of the heparin, is there any way that you can use like a low molecular weight heparin with enoxaparin instead to reduce the risk of some bleeding?
Yeah, so you can use like a Lovenox. Some places do, and they trend their factor 10A. to make sure that they're anticoagulated, but they're still anticoagulated and they're still going to bleed because you have them on the Lovenox, plus their platelets really aren't working the way they should because they're getting the acquired von Willebrands. Any other questions?
What's your opinion on the non-heparinizing the patients on ECMO?
So I think with the new technology, I think you can do it. I don't think you can do it forever, but that goes back to you need to have an end date. Most of these trauma patients that I've seen, if they're young and healthy and they just need a few days for their lungs to recover, they'll be on ECMO for like 3-4 days. And then it's a quick turnaround. So you don't need to have them heparinized if you have a new pump and new system for that long.
So is that a conversation you have with the family before you do it every single time? Like, hey, this isn't happening by day 14, we're done. Like, how does that play out? 'Cause
So-
those trauma situations are
Yeah.
families there, or like there's all these things.
Yeah, some of it is really chaotic. I mean, I've been in situations where we've cannulated somebody in the OR, and then later you find out that they're brain dead, and then you put this family in a very difficult position, and it's terrible, and I never want to do that again. But it happens, I think, when you're in a controlled situation, like MW, his was, he's not doing well in conventional settings right now. We're going to transfer him to the cardiac ICU and cannulate him for ECMO. He has 7 days to turn it around before we withdraw this. If he's not doing better, we're withdrawing it on day 7 and we'll see what happens. And that usually goes better with our cardiac, like medical codes from cardiac or bridge to transplant, bridge to lung transplant, STEMIs, that kind of stuff, just because we do it more often. So I think the cardiologists are more on board and they kind of lead that discussion, but it's something that we're really pushing at BUMC. We're starting a surgical palliative care service specifically for these patients in trauma, and then, the MICU, dead bowel, that everything's dead. What do you do? I'm sorry, that's my picture. What do you do in that situation? So I think once we have that team together, it'll make those discussions more smooth and happen prior to placing them on ECMO.
And then if somebody is transferring a patient to you, because, those patients are, like, even if you're trying to turn them, they'll need, so are there special considerations for, like, the ambulance that they're coming in, or the care flight, or?
Yeah, so I, when I was on my CT month last year, I cannulated some of these people, and what you can do is, if those people are really, really tenuous, you can call BUMC and say, who's on call for ECMO? I want to talk to the doctor. And we can send a team out to wherever you are and cannulate them, and bring our nurse, our perfusionist, a CT surgeon, whoever's going to cannulate them at your hospital with emergency privileges, and then take them in our ambulance with everyone that they need there. Which, I mean, it's worked really well in the past that we've done it. At JPS a few months ago, we had Dr. Kampati cannulate somebody, and he called his heart perfusionists in, and so they did it all there and then sent them in an ambulance, and the perfusionist went with them to BUMC. So usually they find a way to work it out.
I'd suggest, if you haven't already, using the AMA Code of Medical Ethics for some of your ethical questions. It'll help, it won't solve it, because most of the guidelines are into the futility
Yeah.
issues are shoulds and not musts, but
Yeah.
at least you've got a framework that's been discussed and debated at length.
Yeah, and I think that's where the surgical palliative care is going to kind of go with it, is just say, like, these are the guidelines that have kind of been worked out, and I think it's getting everyone on board, which has been the most challenging, is some people feel very strongly one way and the other way. It's like those MICU consults that you get where like taking this person to the operating room isn't just going to be a pre-mortem autopsy essentially. And so we're really struggling with that, and I think I've sat on a few meetings, and I think that's where they're going to kind of lay out the framework. Yeah.
Are there any specific PPE protocols to limit infection while you do the?
With these patients? Yeah, so this is technically a surgery, right? So you're going to use, normal sterile protocol. So when you put in a cannula, the patient's going to be prepped from their belly buttons to their knees with chlorhexidine, just like they are in the operating room. You're going to wear a mask, a hat, a full gown, sterile gloves. Everyone involved is going to be, all the kits that you open are all sterile. It's literally an operating room that's mobile and goes to the patient. And wherever they are, you make it an operating room.
And I mean, so like even for when you're checking up on the patient, we have to gown up?
No, unless they have, like C. diff or something like
Right.
that, then no. When you change their dressings on the cannulas, it has to be sterile, but it's just like any other, central line dressing that you change.
Is there an increased risk for infection?
Yeah, so that's one of the risks is infection. It's a giant cannula, a giant central line in a vein or an artery.
You mentioned the platelets get messed up. I assume the white cells don't do well either.
Yeah, none of it does. These people are a very unique population, and it's hard sometimes, like when things aren't going right, it could be a ton of different reasons why, and it's hard to figure it out. So you end up kind of shotgunning them and sending all sorts of labs off, ordering an echo, ordering every kind of test, trying to go to CT scan if they are stable enough, because it's hard to work it out.
What's like an ideal patient, an ideal situation where you would want to use this?
MW, yeah. Or a trauma patient who has like bilateral pulmonary contusions or fractures, and you're max ventilating them, and doing it early, like trying to prone these patients. I've been in some situations where we flip them over and they code immediately. So I would prefer to do it early. The successful ones that we've had, they make the decision pretty early. They stay on ECMO for like 3 to 4 days, and then they usually get decannulated, and the next day they're on the floor. So if they're young, relatively healthy before the trauma, they can really turn it around quickly.
I'll give you an ideal patient. Because I think of you being a chief resident. I had a 17-year-old when I was a chief resident. I've never forgotten her. She's 17 years old and engaged in conjugal relations with her boyfriend on the diving board of a pool. And at the moment of least attention, they fell into the pool where she hit her. The pool wasn't completely full. Had a burst fracture of C6 and presented to me with a evolving acute Brown-Sequard syndrome and freshwater aspiration. Was an absolute sweetheart. Tried to smile at me every day on rounds around her tube where she's intubated. And her neurological exam progressively improved as her ARDS got worse. We had, this was 1986, we had ECMO kind of tried and discarded at that point.
Yeah.
And she probably would have survived if it had been available.
Yeah.
She was, 17, young, no heart disease, ARDS from this.
Aspiration. And
With an improving neurological system, no brain injury that we could detect, it was all her cervical spine.
Yep.
I will never forget her. It's been a third of a century.
Yep. And that's the perfect patient. Another good patient is somebody who comes in it from a trauma, and like, let's say they're out in the snow and they come in and they code right in front of you, and their blood pressure or their temperature is like 90 degrees or 85 degrees. You can put these people in ECMO and warm them up almost immediately and get them back. We've had multiple successes, one at JPS last year and a few at BUMC, just because of their hypothermic, and you can really warm them up quickly compared to the usual things that we do, like putting chest tubes in and giving them warm lavage through chest tube or Foley, or even opening their abdomen and trying to lavage them. So we've had good success with that too. Any other questions? All right. Thank you.